Thank you for taking the time to listen to this presentation. I'll be going over a complicated course of squamous cell carcinoma in a liver transplant patient. Some background: skin cancers are much more common and aggressive in transplant patients due to the immunosuppression, the most common skin cancer being squamous cell carcinoma. And unfortunately at this time, there are no society guidelines on screening this population, but expert opinion does recommend screening anywhere from monthly to annually, depending on the patient's individual history and risk factors. This patient was a 68-year-old female who did have a history of prior squamous cell and basal cell carcinoma. She had hep C cirrhosis with hepatocellular carcinoma and received a liver transplant in 2015, currently on immunosuppression. She was presenting with chronic worsening facial pain and erythema, as well as some white discharge from the bridge of her nose after receiving 3 courses of antibiotics. So her history is 5 months prior to admission. She developed progressive painful facial erythema. She was actually seen by her dermatologist 4 months before being admitted and underwent a biopsy that showed hypertrophic actinic keratoses. She was treated with 3 courses of antibiotics between her visit with the dermatologist and her admission to the hospital, thinking she had a facial cellulitis. About a month prior to admission, she developed a white drainage from the biopsy site, and a week before she was admitted, she actually developed pain with movement of her right eye, and she was admitted with concern for orbital cellulitis. Her medications were most notable for her being on tacrolimus for immunosuppression, and then the 3 antibiotics she recently was treated with included Bactrim, Keflex, and doxycycline. Her labs were unremarkable and at her baseline. On her physical exam, she was afebrile, normal vital signs. Her face was notable for what you can see in the image, that the bridge of her nose had a mass that was tender to palpation with surrounding erythema. And then she also had a very small area of some white discharge that you could express. Her hospital course was notable for her first day. She was admitted with a head MRI. Infectious disease was consulted, and then some of the purulent material was sent for cultures, and she was started on cefazolin. Hospital day 2, we actually got a CT orbit of her face that was not showing anything concerning for infection, so no local tissue edema, no abscess, but it was concerning for evidence of this mass eroding into her right orbit as well as some of her right sinuses. At that point, ENT, ophthalmology, and dermatology were all consulted. She underwent another biopsy at the bedside, but unfortunately did not have adequate tissue for diagnosis. The following day, she underwent biopsy with interventional radiology, and her wound cultures came back positive for MSSA, likely a skin contaminant. Hospital day 4, her biopsy showed squamous cell carcinoma, and she was discharged with oncology follow-up. After discharge, she got a PET scan that did not show any distant metastases. She was seen by oncology, and then post-discharge day, she was started on chemotherapy with hopes of reducing the tumor burden. After going through several rounds of chemotherapy, she had a repeat PET scan that didn't show any distant metastases. However, the CT orbit did show tumor progression. It appeared to be growing, not responding to the chemotherapy. Plastic surgery was consulted, and post-discharge day 166, she underwent surgery with a large mid-face resection and partial renectomy. She also had her right orbit removed with part of the sinuses, and then she had a fat graft and skin graft placed at that time. You can see in the images here that this was a dramatic transformation of her face, but a repeat PET scan did show that she was in fact cancer-free at this location and did not have any distant metastases. In conclusion, solid organ transplant patients in the literature are found to have about a 5-fold increased risk of skin cancer, with the most common being squamous cell carcinoma. In immunocompromised patients, these cancers tend to be much more aggressive. And of note, it's found that if there's pain at the site of the lesion, this is actually associated with more invasive disease, as you can see in this patient's case. Squamous cell carcinoma is notoriously known to mimic infections or other inflammatory conditions, so can be challenging to diagnose. And also, it becomes particularly challenging that there are no society guidelines in screening for skin cancer in immunocompromised patients. We would actually recommend that they be evaluated by their dermatologist, who can come up with their individual risk and a screening regimen. And lastly, clinicians should always think about squamous cell carcinoma when the diagnosis is uncertain or when the patient is not responding to their current therapy. Thank you.